least 3 years. I'm pretty sure it's Dujmic.
Yes.
It's
great.
Your forbearance is appreciated. So Dora comes to us from Croatia, had a fantastic World Cup experience last time. And so she's taking a very, very broad swath of biology and chemistry courses, and it's kind of fun to see, from a chemistry perspective, the way she's dug into this biochemistry. And so she's going to talk about some more applied stuff about MS. And so we'll see if there's at least one structure in there that we can dig into and say this is excellent. But I'll leave you with
it. Alright, thank you everyone for coming. So our presentation today will be on multiple sclerosis, and I will be comparing lay versus adult onset multiple sclerosis based on my research I did this summer. So first thing we have to touch on is what is multiple sclerosis. So it actually affects 2.3 million people worldwide, and even 1 million of those are in the USA. So it is autoimmune inflammatory central nervous system disease that is triggered by an unknown environmental factor in people that are genetically predisposed to get it. It is characterized with the loss of signal in neurons due to demyelination. It is treatable but not curable disease. And it is also characterized by cognitive and motoric disabilities or decline over time. So first, what is a neuron? So a neuron is basically the smallest unit of the nervous system. Looks like that. So this is the direction where the message travels. We have the cell body right there. We have the axon that actually has a myelin sheath wrapped around it, which I will discuss in my next slide. These are dendrites on both sides of the neuron, and they're actually in charge of synapse, which is the signal transduction. So this is how the myelin sheath looks like up close. This is a healthy neuron in the myelin sheath. This is actually the scarred myelin that happens in multiple neurodegenerative diseases, but especially multiple sclerosis here. So it is wrapped around the axon. And it is here to basically help with impulse travel. And it is in the white brain matter. So this is basically why we have the gray and the white brain matter, because the myelin sheath is actually wrapped around the axon. We can see this on the MRIs as white brain matter. And this demyelination is actually caused by an autoimmune response. On the next slide, we can see this autoimmune response, where we have a healthy neuron right there, where the T cells are actually here as an immune response to things that are not supposed to be in the brain, right? So T cells will actually protect the brain and protect the neurons from any pathogens. In the case of an autoimmune disease, these T cells will actually kind of start to degrade the myelin sheath. The myelin sheath will try to kind of recover from it, but then it will result in scarring of the tissues and actually that buildup, which we can see in MS really clearly. So this is actually like a logic of our healthy neuron, where we have a constant information flowing through our axon. And here we have a successful synapse, so the brain is able to communicate with the rest of the body. Here we have the damaged myelin sheath, and we can clearly see that there's a loss of information. So in this case of MS, the brain will not be able to communicate with the rest of the body, so we'll see various symptoms that we see in MS. So, again, causes of MS are the T cells that cause this demyelination. We have scarring forming plaques that we can see on the images, and there will be no signal transduction. So because of this loss of signal transduction, we have multiple symptoms of MS, which is vision impairment, brain lesions, and kind of the decrease of the volume, of the brain volume. We have spinal cord lesions, mouth and speech impairment, loss of senses, digestive system issues, urinary system issues, and also muscle spasm, which are really common. So, like I said, it is treatable but not curable. These are the 3 most famous medications used for MS. They're shown to be a great in lowering numbers of lesions, inflammations. They actually lower the number of relapses, and they prolong the time of the patient feeling completely better. Also, it reduces disability progression, so it is known to kind of postpone that progression. For example, like patients who take these medications can actually get better for certain periods of time, and also multiple sclerosis is characterized by, for example, walking problems. So these medications will actually postpone that, so it is really short to be really useful. So we can actually put MS in 4 categories. First one is clinically isolated syndrome. Second one is primary progressive MS, relapse remitting MS, and secondary progressive MS. So to start off with clinically isolated syndrome, it is the first episode in discovering MS. It may or may not lead to MS, but in most cases it will eventually. It is characterized by brain lesions or these inflammation spots that are circled right there. They can be anywhere in the brain and also the spinal cord. They are pretty mostly common like on the spinal cord. But yeah, there are inflammation spots and they're kind of the beginning of demyelination in the brain. These may go away over time because it is mostly characterized for younger people, like around their 20s, so remyelination is actually pretty common. Second, we have primary progressive MS. This affects 50% of all MS population, and is characterized by worsening neurological function. So here in this graph, we can see how disability increases over a certain period of time. So throughout time, these patients will actually just keep getting worse. So they're actually characterized by people who get MS kind of like over the age of 40, kind of 35-ish. And this is actually a more aggressive form of MS, where, for example, a patient will come in complaining about kind of tingling in their arm, and they will actually, over a period of time, they will just kind of lose, for example, the sense of their arms, but they're not going to get better. Then we have relapse remitting MS. This is actually the most common MS type, which it actually affects 85% of all MS population. It is actually characterized by these clearly defined neurological attacks and followed by periods of complete recovery. So where this bar is, this is, for example, a patient could come in complaining they can't see from their left eye, and they might not be able to see for like a year, and then for maybe 5 years, they will be completely fine. And then again, they might have another relapse or another difficulty, maybe walking or having muscle spasms or tingling, and then again, they will be completely fine for a certain period of time. These periods of time are not kind of defined, or they're not influenced by anything. They just kind of happen as demyelination occurs in the brain. So they're really hard to follow. Then we have secondary progressive MS. This is actually kind of a second part of MS. No one really starts with secondary progressive MS, but 50% of patients with relapse remitting MS will actually transition here, which you can see in this graph. Here we have these bar graphs where this actually starts as relapse remitting, where we have some cognitive or motor disability, periods of complete remission, and then kind of their function will start looking a lot like the primary progressive multiple sclerosis. So while this is important, we really want to be able to kind of clinically characterize MS and kind of sort it out in as many groups as we can. So for this, we mostly use the Expanded Disability Status Scale, or short EDSS, and neuroimaging using MRIs, which actually became a normal clinical practice nowadays. So to start off with Expanded Disability Status Scale, this measures the level of disability throughout time. And we actually separate it kind of into 2 categories. So from 0 to 4.5, we call this like a minor disability, where a patient might come in complaining, like I said before, maybe muscle spasms or tingling sensations, or maybe some kind of vision impairment, and maybe trouble walking, maybe limping. And then from 4.5 to 9, we call it major disability, where a patient might need a cane or a walker or even a wheelchair. Expanded Disability Status Scale is one of the most common ways to kind of describe disability progression, because it is a scale, so it is very easy to use statistical analysis on it. So that's why we always use this in our trials. Then neuroimaging, like I said, as technology advances, neuroimaging became a clinical practice. It is the best way to diagnose MS, just because we can clearly see demyelination in the white brain matter. There's 2 types. There is structural imaging and functional imaging. For MS, we use structural imaging, specifically the MRI. And just to mention functional imaging, the most common one is the PET scan. The difference is the PET scan actually shows you kind of real-time brain activity. So you can give a person an assignment, they can do it, you can see how like different parts of the brain kind of light up. Unlike the MRI, which stands for magnetic resonance imaging, and actually uses magnetic fields and radio waves to generate images, It doesn't use X-rays or ionic radiation unlike the CT. So for MS, because these patients do have to get MRIs pretty often, this is shown to be a better choice than the CT. We have two types of the MRI. We have the T1 weighted, where the gray brain matter actually shows up darker than the white matter. And then we have the T2 weighted, where the white matter actually shows up darker than the gray matter. On the next slide, we can actually see this comparison. So this is our white matter of the brain and gray matter, so it shows up darker. And the T2 weighted, this is our gray matter. So the T2 weighted is actually used much more often because on this one we can kind of see this demyelination much better, and we can see the lesions in front of these inflammation points. But it is really nice to have both kind of in comparison, so we can actually track those specific spots where we can see inflammations, and maybe see if a person will have vision impairment or inability to walk and stuff, so we can all kind of track that in the brain. So the most important kind of part of the brain that my study focused on and that a lot of research is focused on is the central brain atrophy. So central brain atrophy is actually a great measurement tool for disability and cognitive impairment progression. Its enlargement kind of can show us what parts of the brain are affected, and we'll be able to predict whether the patient will struggle with walking or talking, and actually we can really see like clear demyelination in the brain. So this, like I said, like the central brain atrophy will cause a lot of cognitive and motoric declinement, and we call it lateral ventricular volume. That is the known name in the MS world. So this is how it looks like. This kind of volume in the middle, it kind of has like a butterfly structure. This is just like different views from the brain. We can clearly measure that using MRIs. It actually became a clinical practice now, so almost every single MS patient in the world would get their brain scanned, and they will look actually for this change in volume of the lateral ventricular volume. It's a great disease progression prediction because we do want to tell patients how long will they need to get a cane. So will it take them 10 years to get a cane? Will it take them 5? Will they never get a cane? So like patients do like to know that. So this is a really good disease progression prediction. So here we can compare the two brains. So this is a non-affected brain, so a healthy control. And this is kind of how the central volume should look like. Here we have circled the MS-affected brain, and we can clearly see the enlargement of this central brain. So this patient probably has already like a much more aggressive type of MS. So we can see like a lot of demyelination, even on the edges. We can see a lot of the white matter kind of disappearing. Another comparison, we can compare between types. This is also one of the main focuses because we want to know if relapse-remitting MS will, in the long run, bring higher disability, or will the progressive MS do that. So here on a healthy control, we can see this normal volume. Relapse-remitting MS, we can also see the enlargement. Like I said before, this remyelination can occur in this one. So this one, the relapse-remitting MS is much more unpredictable with MRIs. And progressive MS, this is mostly like the most aggressive form of MS. This is already like permanent demyelination, and this patient will most likely have a much higher disability at this point. So another way we can kind of separate MS is based on the year the patient actually got diagnosed with the disease. So we have three groups. We have the pediatric onset MS, adult onset MS, and late onset MS. My study actually focused on adult onset and late onset MS just because pediatric onset MS is really hardly comparable, and it also affects a very small percentage of people. So it is a multiple sclerosis that is diagnosed until the age of 18. It affects only 2 to 5% of all MS patients in the world. It is mostly characterized by relapse-remitting MS, and it is also known to have these long periods of remission, and it has a much slower disease course. The issue with this pediatric onset MS is that children who get this, or adolescents who get this, in the long run they will have a lot of learning disabilities. There was also mention of autism, a lot of anxiety, depression, all due to development of the child when they actually get this disease. Adult onset MS is the most common type of MS. It is MS that people get from the ages of 18 to 40 or 50. The reason I put 40 or 50 there is that actually literature is not really there's not really like a clear line to whether we should see adult onset as 40 or 50 years. In my study, it personally shows 40, just because there's not enough literature and actually shown to be a much better choice than 50. It is mostly relapse-remitting MS, because these patients are actually known to have a really, really long disease duration. So they might have multiple sclerosis for maybe 20 or 30 years before actually getting a cane. So it is a very, it is a disease that like people can't really live with, especially these days. The lifespan actually of these patients enlarged greatly throughout the years. Then we have the late onset MS, which was actually one of our focuses. It is over the ages, it is MS over the ages of 40 and 50. It only affects 4 to 9% of all MS population. Recent studies correlated it with much faster brain atrophy and disability progression. It is mostly primary progressive multiple sclerosis, which is a more aggressive form of MS. But even though they would be diagnosed with relapse-remitting MS, they will progress into secondary progressive MS much faster compared to younger patients. The issue with late onset multiple sclerosis is it is often misdiagnosed. So many times, that is why kind of the literature lacks evidence about late onset MS, because oftentimes before the neuroimaging was very advanced, they often misdiagnosed it for Parkinson's disease or Alzheimer's disease or some other neurodegenerative diseases which were also characterized with demyelination. So what is the importance of all this characterizing MS patients? So to improve therapies and medications is always a big one, because we do want to make as individualized kind of treatment as we can. We really want each patient to have the ability to get better. And there is a lot of medications out there, but all of them have like different side effects. And then the ability to predict disease outcome, this connects a lot with improvement of quality of life. Just like cancer patients, MS patients also would like to know how their disease is going to go if they're diagnosed. So the ability to tell them when they're going to get a cane or when they're going to have an issue walking or talking is really important. To improve quality of life, their life already improved significantly over the past decade. So yeah, like I said, the lifespan of MS patients increased greatly, which is always a great thing going into medicine. So one of the papers that I found that was really interesting is called Time to Reach EDSS Score of 6. So EDSS Score of 6 is the scale I showed you before, and the EDSS Score of 6 is actually the use of cane. So these are patients who need a cane with walking, they're not able to move by themselves that much anymore. And on this graph, we can see kind of the survival axis, and then these are the times to reach this EDSS of 6. We have two curves. One of them is young onset MS, which is the same as adult onset MS, they just call it differently, and late onset MS. So this green line is actually late onset MS, and we can see that they took significantly less time to reach EDSS 6. So like on average, maybe around 7 years, while young onset MS, they took even up to 15 years to reach that EDSS score of 6. So this is really important to know. So basically what the research doesn't really know what's happening is that if a patient who is 20 gets MS, will they need a cane in 30 years? Or if a person who gets MS when they're 50, will they get it in 5 years? Or does it not matter, or when you reach 60, you're going to get a cane either way? So this is something that all studies are trying to prove. Another study really tried to characterize late onset by actually following a group of patients for 5 years. So this is the graph at their 5-year follow-up. So this was their last appointment, and they kind of separated into 4 groups. So this group right here was no difficulty walking or moving whatsoever. This one right here is some kind of impaired walking, maybe limping, but they could still get around just fine. We have group C, which is use of cane, walker, or wheelchair. And then D is patients who are confined to a wheelchair. So at a 5-year follow-up, group C, which is the use of cane, walker, and wheelchair, seemed to be the biggest group, which is a really interesting finding because it did show that they did progress a lot over time. What this study actually misses is the comparison to the adults. But their goal was to see is late onset even a thing? So does that even exist, or is it just something that we just kind of put a number on? But they did show that late onset multiple sclerosis did get a cane much faster. So this summer I did a research in Buffalo University. It is called BNAC, Buffalo Neuroimaging Analysis Center. They are known for actually doing a lot of MRIs. They have huge longitudinal studies throughout 10 years, and this is the one that I was working on. I wasn't actually involved in the collection of MRIs, but I was kind of the person who got all the data and then sat on a computer and analyzed a bunch of stuff and did a lot of statistical analysis. So we had a large patient cohort, which means like a large patient study. We had over 2,000 patients in the end, but when I excluded a lot of them, for example, we excluded pediatric onset, we excluded people who didn't have the correct MRIs because it is 10 years, so a lot of things change in 10 years, which is a lot of issues with these studies. So in the end, I got 870 patients, which is also really good. It is a huge number of patients, so it was a really great study. Like I said, it lasted throughout 10 years. So what I was working on, I had all the collected MRIs. We actually used this program, this MRI called NeuroStream, where we actually measured the lateral ventricular volumes, like the central brain atrophy, and we were checking if their volume of that central brain atrophy would change. We had the EDS scores for every year throughout 10 years for each patient. And so what we had to do is basically divide them into 3 equal categories so I could statistically do the statistical analysis. So the first category is late onset MS patients. So we had 290 late onset MS patients, which we defined them as anyone who's gotten MS over the age of 40. So if you got MS over the age of 40, you're in this category. And then we randomly matched adult onset MS patients who have the same age as every single one of the patients right here. So they were equally matched randomly, which was really important. And then we had another category where we took adult onset MS patients who had the same disease duration as the late onset MS patients, and we matched them all together as well. So now we had 870 different patients, and we wanted to see how, like basically how will they change over time? How will the central brain atrophy change over time? So we had to put them into tables, and this is our demographic characteristics. So here, we just wanted to see how basically our cohort looks like. So we wanted to see how much percentage of females we have, although we did not really focus on gender in our study, but like it is always useful to see that. The mean age of late onset MS patients was 53 years old, and for comparison, the disease duration matched AMPs were actually around 10 years younger than the late onset MS patients. They kind of had the similar amounts of follow-up, which was around 55-ish. And also the disease duration, which was really important to remember, is that late onset MS patients had an average 7 years of duration, so they had MS for 7 years, while adult onset MS patients who actually were the same age as late onset MS patients had more than double disease duration. So that was a really interesting finding. And then clinical characteristics we were actually looking for is we were looking at lateral ventricular volume, and we used NeuroStream to do that. So it is just like an MRI we used. So we measured, actually we had three data points. So a baseline, which means the beginning volume of this lateral ventricular volume, and this was at the first appointment they had with Buffalo University. Then we made the percent change from then to the most recent follow-up. And then we annualized that percent change to get kind of the best comparison we can. So what I was doing, I was checking for statistical significance using non-parametric t-tests because it was really impossible to kind of normalize the data. So I was looking at p-values, and basically if I got a p-value that was smaller than 0.05, I confirmed my null hypothesis, so there was a difference, so I could actually make a conclusion from that. Or a p-value, if it's larger than 0.05, I actually rejected that null hypothesis. So looking at our data we got, right from the beginning, this is like our lateral ventricular volume as baseline. So at baseline, actually the largest volume was in adult onset MS patients, which was actually really interesting because you would think that they have the highest kind of rapid brain atrophy. And then kind of late onset MS was in the middle. So based on looking at just this, we couldn't really conclude who has the more rapid one. When we look at the total percent change, that already changed them now. So late onset MS patients had actually the largest percent change over that like 53 months of follow-up. But then if we annualize it, we had another great data where we have 4% change annualized for late onset MS patients and only 1.6 for age-matched adult onset MS patients. So what this basically means is that late onset MS patients got it later and they took a lot less time to kind of lose the volume of their white brain matter. While adult onset MS patients who are maybe 50 right now, they are still not progressing as fast, even though they're the same age. So here what is really interesting is we wanted to see how aging maybe will have an influence on that. We maybe thought that once you reach the age of 50, it doesn't matter when you got it because you're aging either way. But apparently not. For our study, even though they were the same age, if they got it before, they haven't progressed as much, which was really interesting. The reason for this might be because when adult onset MS patients are young, they have a much higher rate of remyelination, so their brain is much faster in recovery in comparison to late onset MS patients where we already have some other aging symptoms, so the brain kind of slows down to begin with. So multiple sclerosis in that case might have just like hit them a little bit harder in that case. So what is important for kind of the future research of multiple sclerosis and mine in general? I was actually attended a conference where everyone asked me questions about the hypothalamus volume because this is the newest kind of trend in multiple sclerosis society where they look at the hypothalamus volume because it actually correlates with disease activity and disability progression as well as essential brain atrophy. So a lot of actually new research is looking at that volume because this has not been in practice so far whatsoever. Another one that I got questions about is actually the spinal cord lesions, number and volume, because spinal cord lesions are mostly characterized in the beginning of the disease and then after a while they kind of don't screen it anymore. But actually more spinal cord lesions equals greater disability progressions in a lot of studies lately, which is actually really, really interesting. And then there was a lot of papers trying to make an actual like software or like computerized programs where patients could actually the doctor could take all the data from the patients, they would put it in this nice program and the program would just tell them in 5 years, this is how your disease is going to look like. So a lot of these programs are kind of based on this expanded disability status score where a doctor will examine the patient, look at the patient for a few years or like every month or whatever depends on the type of the disease. They will put it in a computer and they will kind of annualize the percent change. So they will know maybe in 10 years you will reach an EDSS score of 6, which is really, really beneficial for a lot of these patients. So yeah, that's pretty much that. I would like to thank s0nd, he's unfortunately not here, for being my great advisor, David Hall for teaching our class and helping me with feedback, my class of chemistry 680 for giving me amazing feedback, friends, Buffalo University for this amazing opportunity, and thank you for coming.
Questions?
Can you talk a little bit about the differences between white and gray matter and where the lesion do you find more lesions in like a certain type of that?
Yeah, so part of the brain affected by MS is usually white brain matter, just because it is the most, like the biggest kind of volume, and the demyelination, the myelin sheet is only like in white brain matter. So demyelination on the scans can actually be seen right there. And with the T2 weighted MRIs, we can see those inflammation points really clearly because the white matter is actually darker than the gray matter. So yeah, it is only the white brain matter because that's where most of our kind of cognitive disability or motor disability happens.
Other questions? Thank your speaker again.